This CME activity is sponsored by the Hawaii Consortium for Continuing Medical Education, a joint venture between the Hawaii Medical Association and the John A. Burns School of Medicine. At this time, please enter the name and credentials of everyone viewing Grand Rounds for CME attendance purposes. As a reminder, evaluations are required for CME. You can find the evaluations by following the link in the chat at the end of this session or at any time on our website or email advertisement. Your comments are very important to the planning committee. As you know, all sponsors of CME are required to execute a conflict of interest policy. All presenters have disclosed that they have no relationships with commercial supporters that could be perceived as a conflict of interest in the context of this presentation. It is my great pleasure to welcome our three speakers for today. Dr. Ray Seitz is current chairperson of Hui Pohala, an organization committed to improving access to high-quality palliative care for those with serious illness in our community. She provides leadership to the Vital Talk Hawaii Consortium. She has been a palliative care specialist since 2001 and has built palliative programs for Kaiser Hawaii and HMSA. She firmly believes that the collaborative nature of people in our community enables us to innovate and improve care for those with serious illness. I completely agree with you, Ray. Our other speaker is Elizabeth Freitas, who's a clinical nurse specialist with advanced certification in hospice and palliative care and oncology. She has been at the Queen's Medical Center for many years, where she has served in several roles in oncology, neuroscience, and most recently in palliative care. Her current interests are spirituality and emotional intelligence in the area of palliative care. Dr. Ridabel Fernandez is an associate professor at the Department of Geriatric Medicine, John A. Burns School of Medicine. She's board certified in internal medicine, geriatric medicine, and hospice and palliative medicine. She has many years of experience with low-income and medical served communities at federally qualified health centers in Hawaii, as well as training of community health workers. She has also taken leadership in training in the US Pacific Islands, where she has developed curriculum in palliative care, family caregiving, and dementia. Please welcome our speakers. We're going to be talking about the Vital Talk program.
Good afternoon, and thanks for having us. We're really excited to talk about this project. It's taken a lot of effort and a lot of blood, sweat, and for some of us, tears. Next slide, please. But we are so happy to be here. Just to let you know that I am the chair of a new organization called Hui Pohala, and our vision is to expand access to high quality palliative care to everybody in the state who suffers from serious illness. Next slide, please. I don't have any financial disclosures to make, and I believe neither do the other speakers. Next slide. So today we're going to be talking about Vital Talk, and I'm really excited about this project. I think we're already seeing a lot of benefit to it. Today, we're going to identify the unique approach developed by Vital Talk to teach healthcare professionals essential communication skills, because we want to enhance shared decision-making in our community. You'll be able to contrast and compare a tough clinical conversation with a patient, seeing both what it looks like with and without the skills taught by Vital Talk. And I hope that at the end of this, you'll list ways that the Vital Talk training has impacted the clinical practice of other healthcare professionals. And the other people on the panel will be speaking about their specific experiences as a result of this. Next slide, please. So before I start talking about what's behind the scenes of Vital Talk, I'd like to give you a view into what it looks like and compare that with what an encounter looks like without Vital Talk. John, can you go ahead and play the video?
Of the Vital Talk training, you'll be thrown into scenarios with an actor and have to deliver news about serious illness. So we're going to encounter a patient who's 40 years old, who has just been diagnosed with colon cancer, has went through their staging and their scans, and now it's come back that they're stage 4 and it's metastatic. And I'm going to have to meet with this patient and deliver this news. Hi, Christine.
Hi.
Thanks for coming in today.
Thank you for having me.
I know that you went for some CAT scans last week.
Yes.
And I wanted to share some of the results. So the results of the CAT scan showed that there is some tumors that have spread to your lymph nodes and liver, which makes the cancer stage 4.
So I have cancer in my colon and in my liver and in my lymph nodes.
And lymph nodes. And
Okay.
it's not liver cancer. It's the cancer's in the liver, but it's actually started in the colon and spread to the liver. So you have colon cancer, but it's stage 4.
And
colon
how
cancer.
how did I do something? Like in my diet, or I had problems with drug abuse in my early 20s. Could that have been a thing? I mean,
The cancer, there is some genetic possibilities when it comes to
Genetic?
colon cancer. Yeah, but it's not everybody.
how much is all this gonna cost?
Oh,
Like,
I don't really know
treatment?
exactly
Okay.
because it depends on insurance and co-pays.
How long do I have to live?
I don't know if we
I need
could
an
even say
estimate
that.
or something
Yeah,
of people in my situation.
I think maybe getting you to see the oncologist.
You
is
don't
going
know?
to be, well, it's so
Usually,
hard.
you know, like they have estimates, like a month, 6 months, 4 weeks.
Yeah, it depends on your response to the chemotherapy.
Can you ask someone? Flip to another page in your
Yeah.
little book?
Well, a lot of it depends on
On what?
like your function.
My
and-
function.
Yeah.
I'm asking you.
That's where I think the
Do you need to call someone? Call someone. Do I need to go in the hall and find another person? Because it doesn't help. It never helps talking to you.
The encounter that we just had wasn't very good. I could sense a lot of emotion, but I just didn't know what to say, or I didn't know how to respond, and kind of felt stuck. So in the second scenario, we're going to be able to practice and be able to deliver that same news by using a tool that's provided by VitalTalk and be able to see how we can do it better. The nurse tool stands for N for naming an emotion, U understanding, R respect, S support, and E explore. Our intention is that you're not supposed to cure or get rid of emotion. The intention is that by acknowledging emotion, you can have a chance to have a patient felt heard and allow a patient to hear more information and to process the information that you're trying to share with them. So in this next scenario, we're going to be using the nurse tool to help respond to a patient's emotions. Hi, Robert.
Hey, doctor.
Thank you for coming to the clinic today. I know that you had all your CAT scans and imaging last week. I do have the results of all the tests. Is it okay that we're discussing the results right now?
Yes, yeah.
I wish I had better news, Robert, but the scans do show that the cancer has spread to your liver and lymph nodes.
You tell me it's worse than before? We did the treatments, we're doing everything. I changed my diet, come on.
You know, Robert, I can see this must just be so hard to hear right now.
I thought we could beat this. Oh, man.
I want you to know that you have done everything we've asked for you to do, these tests, the treatments.
I know, I did everything. I could beat this, doctor. I thought I could beat it, man.
I'd like you to know that I'm gonna try my best to help in any way possible. Can you tell me, Robert, what's your biggest worry right now on your mind?
It's my kids, you know. They need me right now. My son really needs me right now. He's, yeah, there's a lot drugs, you know, that stuff. That same thing I did. I was his age. I was doing the same thing, but I know how to get him, you know, set him straight. Like I'm the only one who can do it, and my wife's really struggling with it, and he's really just right on that edge, you know, like, and I gotta grab him. I gotta stop him from going down that path, you know.
Thank you for sharing some of these things. It really helps me understand more about what's going on, what are the important things, and I want you to know that I hear you, and we'll be in this together. Knowing about the results of the scan, I'd like to be able to share what's the next steps. Is that okay?
Yeah, I guess I want to know, you know. There's probably a lot to think about, right, to prepare for, and I don't want to think about it, but I need help with it, for sure.
Why don't we take this together, a step at a time, and maybe then the next thing we can do is get your wife involved and updated. I really want to be there as a resource to you guys.
Yeah, my wife's gonna be so disappointed. We were just talking about, you know, that we're gonna get through this, and she's gonna be so disappointed. But I appreciate it, though. It's gonna help.
So by using tools such as Nurse, it allows you to provide empathic statements that allows patients to manage their own emotions and be able to have the space to process and hear the information. This allows them to be involved in decision making and empowers them to be able to be a part of their own care.
Okay, so in the slide deck are links to two videos, that one and another one that we did as part of this Vital Talk project. But what is Vital Talk? Well, it's an educational program to teach people improved communication skills. Vital Talk is an organization, has a vision that every seriously ill patient will be surrounded by clinicians who can speak about what matters most and match care to values. So that's what they're aiming for. Their mission is to integrate evidence-based serious illness communication skills into healthcare practice through an engaged network of trained faculty. Next slide, please. When we embarked on our Vital Talk project, we convened a Vital Talk consortium. And these are local organizations and individuals who decided that Vital Talk was an important way that we could improve shared decision-making in our community, especially for people with serious illness. We crafted a project in which 12 people who live and work in our state were trained to become Vital Talk faculty. And these 12 are listed here. As an agreement to being offered this training, each faculty member then committed to conducting 2 to 3 trainings per year for 2 years. And in that way, we felt that we could substantially ground Vital Talk in our communities and help to build significant spread. We are now making plans for funding to get a second cohort of faculty trained sometime within the next year. Next slide, please. So, you know, when I think about good communication skills, there was a time when I really felt that good communicators were just kind of inherently good. They were just born that way. They had this natural talent. They could talk to people. People could share things in a very open way. It felt very collaborative. It never occurred to me that you could actually teach these skills in a very significant way. I thought that was just an inherent ability. I've also heard from people, other providers, that they really don't want to provoke any kind of emotional response. And so how they share information and how they conduct goals of care, communications, and things like that is tempered by trying to avoid too emotional a response, because those emotional responses are thought to be too messy, too complicated, for the provider, too emotionally draining, and takes too much time. We've all heard those reasons for not going down that path of trying to address emotion. What Vital Talk has taught me is that communication skills can be learned, and so can be taught in very effective ways, and ultimately can lead to more effective, efficient, and satisfying shared decision-making. Next slide, please. So what happens in a Vital Talk training that makes it really kind of different than other trainings that you might have been involved in? First of all, they really pay attention to creating a safe learning environment for the learner. They attend to the smallest detail. And I've done an additional training as a faculty member to really get to understand what's behind the curtain, what's the pedagogy that informs a Vital Talk training. And there's a lot of attention to really attending to the angst and the anxiety that is naturally found in learners, particularly professionals, and particularly when they're kind of put on the spot. Vital Talk focuses on the significance of emotion and emotional responses, and they have a whole understanding about why you must expect and address emotion, because the way the brain is constructed and how our brains have evolved over time, that when a threat comes to us, it's not the cognitive part that's going to jump in first, it's going to be the emotional part. So we need tools to recognize those emotional reactions and enable the learner to respond with empathy. And I would also say to build some resilience in the learners to deal with an emotional response from their patients or families. In addition, Vital Talk really highlights the importance of language, and they spend a lot of time parsing the language out and having learners practice very precise language. The other thing is that they make the experience of the interaction, which is simulated, but they make it as real and authentic as possible. Next slide, please. So how do they do this? So if you can understand why emotional responses not only are expected, but if they don't come up, you should be wondering why, because these are patients who are receiving significantly challenging news about their conditions or what have you. By giving the learner simple tools, they give them things that they can use already in real time, and that it doesn't take huge lift for them to begin to master. This then enables them to focus on the larger issues at hand, because they have some tools to help them along. Those tools have to be simplified and they have to be practiced. So part of the training is being clear, reviewing what the tools are, and then practicing and drilling. Just practice, 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 repetitive drilling, frequently reviewing. And that really helps to cement some of these tools into our brains. The other thing that they teach us is forgetting is learning. So when we show up the next day or the next week for training and we've forgotten things, that's okay, because they spend time reviewing. That whole process actually helps to cement the learning more firmly in our brains. Lastly, what they do is to teach us to recognize when to intervene in such a way and at such a time as to maximize learning and minimize learner angst. Next slide, please. Making the experience as real and authentic as possible. This is a very cool thing, you know. When I've run other trainings that were homegrown, we would recruit colleagues or friends to play patients. What Vital Talk does is it requires that professional actors be utilized and be trained so they understand what the intent and the purpose of the interactions and the cases are to elevate learning. The other thing is that we here in Hawaii and nationally Vital Talk as well, we really pay attention to the cases that are conceptualized, crafted, vetted, and put forward as the learning cases, because we want to make sure that they are authentic to the experiences that our providers here are having. We also have learned that, you know, out of COVID, the Vital Talk training was remote, was virtual, and we weren't sure that was going to work. But what we found was that even in that kind of a setting, they were able to preserve the genuineness and the authenticity of the experience. And as an added bonus, it's really helped people to use it in their telehealth experiences as well. Next slide, please. So there are basically two levels of Vital Talk training. The first is mastering tough conversations. And I want to be really clear about Vital Talk training. It's pretty intense. It's pretty involved. Mastering tough conversations is an intensive 3-day training. Each day is about 6 hours long. And it's conducted by experienced Vital Talk faculty. If you want to become Vital Talk faculty, mastering tough conversations is a prerequisite and allows you then to enroll in the actual faculty training, which occurs in 2 blocks. Each block is 3 days long, 6 hours each day, and separated by a short period of time. Once you complete faculty training, you have access to Backstage, which is where all the Vital Talk materials exist, including explanations about the interventions and the teaching tools. At that point, if you become faculty trained, you can teach what is branded as powered by Vital Talk trainings. And we in Hawaii have done a few of those, including by 2 of our panel members. Next slide, please. They'll talk to you a little bit about that. So with me today are Beth Freitas and Rita Bell Fernandez. And I will say that when people were asked to join this endeavor, they were selected because they were noted already to be highly skilled teachers and very effective communicators. So it's interesting to me that even at that high level, I'm really interested in hearing what their learnings were going through this this training. Next slide, please. Oh, sorry, go back. So if I could start with Beth, I'm gonna pitch some questions to Beth and Rita Bell. And for those of you in the audience, you can use the chat if you have questions. I think Kamal is going to help us to monitor the chat and to make sure that we cover people's questions. So let's start with this. Beth, and Rita Bell, what trainings have you led using Powered by Vital Talk since becoming faculty? And what kind of responses did you get?
The first education session that I did was to the advanced practice nurses at the Queens Medical Center. We do every other month educational program, and mine was really about talking about those difficult conversations and gave them little scenarios and how they would respond and little tips. So that was just a brief, like 1 hour session, and I talked a lot about nurse, which thankfully Dr. Nguyen described in his video. So that's really about how to respond with emotions. And the second part of that was to try to talk about another concept or tool called headline. I've been an advanced practice nurse in palliative care for many years, and I really thought that I had the skills to give a great informational sharing to a patient and their family, and I was sorely mistaken. A headline has been just a great tool, and I'll describe it quickly. It's you give the medical information in words and language that the patient and family can understand, and very short. 1 sentence, 2 sentence max, and then you tell them what you're worried about that, and then you wait for them to be emotional, because they are going to be emotional, and you respond to that emotion. And so that was really important for me to help my other APRN colleagues learn about. And then more recently, I was able to do a training with some neurologists and oncologists with APRNs and physicians. And they were great students. They learned really quickly the language and to communicate with their patients in a totally different way than they felt that they had tools or skills to do before. One little snippet is I had someone who responded who talked about how when the patients, are given that stage 4 diagnosis, I just really want to push to get them more treatment and get them more treatment. And this was really an insightful thing with Vital Talk, is they could really actually hear maybe more about what the patient wanted and where the patient was coming from, instead of just the quote, do everything, really what was important and valuable to that patient moving forward with this bad news. So.
Rita Bell and John, can you put up the slide that had CHW on it? It was, yeah, the next one. No, the one before, sorry. The one before. There we go. Nope.
Thank
Nope.
you, John.
Perfect.
Well, Ray, thanks for inviting me to the panel and for allowing me to be part of the Vital Talk faculty training. This has been a wonderful experience, and I was very happy to share it with the Community Health Worker certificate program. So the opportunity I got was with the Maui Community College and their instructor, Celine. We did a Vital Talk Mastering Tough Communication via Zoom. And you might ask, what would a community health worker do, or an outreach worker have to do with Vital Talk? And they are critically involved with patient care. They help to build trust in the community. They are advocates for the patients. So we had to modify the training a bit to give them a tool that they could use. So the talking tool that was used for the CHW was Guide. And a community health worker does serve in a role as a guide, because they are the ones helping the patients navigate this maze of our current healthcare system. So next slide, please. Let's look at this tool, Guide. Now, Guide is when a community health worker is working with families in their homes, maybe at a clinic, at a FQHC, they can help families when discussing serious news, whether it's a diagnosis of dementia, whether it's a diagnosis of cancer. GUIDE stands for G, get ready. You know, one needs to have the right information, the correct people around the table, the right place and time. So G is get ready. U stands for understand. Understand what the patient knows, because one has to begin with some baseline. I is for inform, starting with a headline. And we did train them on how to give a good headline. And I had co-facilitated this training with Dr. Toby Smith, and he did a wonderful job with practicing headline. In fact, we gave them as a start to practice the Russia-Ukraine, and we said, come up with a headline with that. So we started from something that was familiar to a healthcare setting. D is for demonstrating empathy. And here the nurse statements come into play, where you verbally demonstrate your empathy. Because in today's Zoom world, you can't hold a patient's hand, you can't give somebody a hug. We are now in telehealth and a different time in medicine. So one has to use words to demonstrate empathy. And the final part of GUIDE is E for equip. You're equipping the patient for the next step. And that's important because there needs to be some follow-up. We're not abandoning the patient. They're not just left to themselves and to figure all this out. So a CHW can function very well as a guide, and this talking map was very helpful, and it was well embraced. The feedback we got from the students, the Maui students, were they couldn't believe how real the encounter was. It's like chicken skin. You know, when you are with the actor, it is amazing how real the encounter becomes. So even via Zoom, it was well received, and thank you, and thank the GWEP grant who funded the actors' time. And we're very grateful to the CHW certificate for allowing us to bring Vital Talk training to the Maui Community College.
Great, that's amazing. That's fantastic, because very often we don't think about those, that level of caregiving or provision of services as appropriate for having these kinds of conversations, but they're in these people's homes and developing relationships. So Beth, what was different about the Vital Talk training as unique from other forms of communication skills training that either you've done yourself or that you've participated in?
Well, I have had the pleasure of having different types of education regarding communication skills, emotional intelligence training, nonviolent communication training, and I've had multiple roles in my profession: a staff nurse, nurse manager, clinical specialist, director, and I've had the ability to talk to patients, families, nurses, doctors. The Vital Talk training is great because it's a system. The second thing that's really great about it is the live actors and the practice. So you're practicing in front of your peers, which tends to intimidate all of us who are highly desirable to look perfect and be perfect when we're doing our work. But the hired actors are so real that it's very easy to get into the situation and communicate with them like you would a patient or a family member. The best thing about it is that you can try different skills and you can try things that you've never done before and see how well they work or they don't work. And you can't do that in real life. And so it gives you really that freedom to talk and speak and communicate differently than I've ever done before, or even when I've taught other students to improve their communication skills. I think it's really, that's the big key, the practice. And we call it, kind of getting in the hot seat and doing it. That's what's so impressive with Vital Talk.
Rita Bell, what are your thoughts on that? How is the training different?
Vital Talk training is unlike any other training I've had before. And I feel the actors make a huge difference having trained professional actors. What Vital Talk does is it gives you some magic words. Now, I look back at my life. It was in kindergarten I learned, please say thank you, please, excuse me. We teach kids these magic words. And here we are in the field of medicine, and no one has taught us the magic words when having these difficult conversations. So I was very grateful for the simplicity of these empathic statements. It just makes it so easy to use. And then you see the results. That's also impressive. And you see, oh, I just said that and look what happened. Oh, wow. I was very impressed with the tools and the maps that were given to us.
Yeah, it's really, it belies the complexity, the way they're able to really distill down to very simple tools, words that you can remember, and because you need to remember to be able to apply it, right? But the way they're able to get that into your brains is really pretty remarkable. And they do it on a very conscious level. I'm really interested in like, what in your own ability or your own, teaching skills, what insights did going through Vital Talk provoke in terms of your understanding of yourself? Rita Bell, why don't you start?
It showed me my big hookah. I was like, oh my God, I don't do that. I realized in the ask, tell, ask. So there is a training or a talking map of ask, tell, ask. And I realized that I do not ask permission. Often I'm giving the results of the CT scan or giving the results of the blood test or the A1C or the mini cog, and we're discussing all these things, but I fail to ask permission from the patient. Would you like to know the results of your CT scan? And I realized that was sorely missing in my own tool set. And probably I'm always rushed for time. You know, in the clinic, we have 15 minutes for an appointment and we have to move fast. Mm-hmm. So often I have skipped that step, and that step is so important to ask permission. So I became more aware. It created self-awareness, and I'm conscious now when I'm in a clinical setting to remember to ask permission.
How about you, Beth?
Thanks for that extra time, Rita Bell. The piece that's was really eye-opening for me. So there's another acronym called REMAP. And after you've asked permission, told, responded to the emotions, you then ask again, what's important to the patient hearing this news? I feel like a lot of times previously in conversations, when talking about code status, because we're really talking about difficult decisions in that sort of end of life period, Vital Talk is, this Vital Talk program. I've gone to the part about educating about what CPR would look like, what intubation would look like, et cetera, and gotten this kind of smorgasbord answer from patients or families. Well, I want this, or I want that, and I don't want this, or don't want that. So really talking about their overall goals first, because they're the expert in their goals. They know themselves, their bodies, what they want, and their values. And then taking my medical knowledge and then offering what would support the goals the best. It's been so much, conversations have gone so much faster. Using that specific tool, I've really gotten to know the person better, which to me is why I went into the nursing profession, is to connect with people and not the technology part. so I found that that simple switching of telling what we should do, but asking first what's important to them. Well, I probably had been taught that, the switch just flipped for me after doing the Vital Talk training. Really putting it into practice and really applying it on a daily basis.
One of the hardest things for me, which some people might find kind of interesting, because I'm a very direct person. Often I have no filters and stuff, but the whole notion of headlining, of being able to very concisely, precisely, and clearly deliver information, even though it's really bad news, I found very challenging for myself, because, we're taught first do no harm. And it looks like that emotional response that a person has to bad news is doing harm. What Vital Talk taught me was, you're not doing the harm. You're giving them information, and that emotional response means that they have heard. They have heard some of the truth and data and evidence that you are trying to give them and trying to share with them, which they need if they're going to be an active participant in their own decision making for their care. So I struggled with that a lot.
Me too, Rita. And if I could add on to that just a little bit, I think the part that helps me with that, because I'm a circular talker or discusser about those things, is that I ask that permission first. Can I give you this? So then I'm like, okay, I've asked permission, and now I can give a headline that to me in my previous life before Vital Talk would feel like too direct, too pointed, and too difficult for someone else to hear.
Oh, that's a really interesting insight, because the other part of Vital Talk is, I think, recognition of our own kind of emotional responses and our own anxieties and angst and need for some safety. Yeah. Okay. So my last question to you, and then we want to open it up, is would you recommend the Mastering Tough Conversation training? Again, 3 days, 6 hours every day. And would you recommend, for some people, becoming Vital Talk faculty? Rita Bell, do you want to start?
Sure. I see a lot of colleagues on this grand rounds, and so many of you are mentoring medical students, fellows, residents. This is a perfect tool. It would be great to become a Vital Talk faculty, because you can not only use it with the patients, you could also use it with the students, residents, and fellows, because it teaches you how to empower them, and they will get a learning lesson that they can take forward to the next patient. And I wish I had this when I was in medical school, but that was a different time and place. And this is a beautiful training that is very simple, and it will empower mentoring and learning and facilitation here in Hawaii. So as many of our colleagues on this grand rounds, I would encourage you to please consider the opportunity of becoming a Vital Talk faculty and trainer.
Beth, did you want to add?
Yeah, I would like to add. So knowing, as Rita Bell says, most of these people on this conversation, I would highly say that you have the basics and skills, and this just really adds more tools to the toolkit. So I would definitely recommend going on. And why I recommend probably more the trainer than just staying with the first core course is to continue to use and practice the skills. I mean, just getting ready to do another training, like my skill level jumped, considerably, because I'm putting it to use, and it's, what you teach, you tend to use more often. So I would highly encourage it. And I was a naysayer at the beginning, feeling like pretty overconfident in my skills. So I can say that I came from one of the recruited people versus the volunteered people.
I know that Crystal Costa is out there in the audience, and Crystal is our project manager. Crystal, you wanna just kind of give them a rundown of some of the trainings that the newly minted Vital Talk faculty have done to date and what is planned?
Oh, they've been absolutely incredible. It has been such an experience watching so many of you go through the trainings. This year alone, we have done 2 cohort sessions with Hawaii Pacific Health and training a variety of their providers. And what's becoming really interesting is that the training is no longer just one type of provider. They're becoming interdisciplinary too. So it's the physicians, the nurses, the community health workers, and in the single training, they're having social workers, navigators, multiple people involved. And so they're watching them do the training together and be so supportive of one another and learning what each role is doing at different stages has been phenomenal. Has been absolutely so enriching to see different people navigate different types of the scenario within the same training session. So we've done one in January and February, and then we did one in April. We finished recently the geriatric fellows, hi fellows, and then we have the internal medicine pilot coming up. And that pilot is going to be for the first group of 6 with the intention that eventually we will train all of the classes. So that's the next step project, and pushing it more through the GME world on the graduate medical education side. So we have a lot of work to do and our facilitators will be very busy. So we'll be in touch. You'll see more of us.
Okay. Thanks, Crystal.
So Ray, Rita-Bell, Beth, and Crystal, thank you all for this wonderful effort. It is very appreciated. And thank you for doing the fellows. Dr. Wen did them just a couple of weeks ago, and I know they really appreciated it. I think my concern is this, Ray, maybe you could address this. You know, these trainings happen in small groups. They're really most effective in groups of 6, I was told. And so I'm having trouble. We want to do this as a faculty development activity for our department. I'm having trouble getting trainers to do it. Because they just don't have enough time to do it.
Oh,
to
because
so many sessions.
you've got to do multiples. Yeah,
that's
well,
right.
You know, so we there are 10 faculty on the ground in Hawaii right now. We trained 12, but 2 of them moved away. One of them we could you know, have help, and we'd like to have 2 facilitators per training, because the support and the being able for one person to be engaged and the other person to observe is so valuable. But the bottom line is that you've got access to 10 people. So you should reach out to Crystal and the consortium to figure out how we can get as many people into, you know, these trainings as possible. The other thing is that we are seriously pursuing additional funding. This is a really pricey endeavor, but we're pursuing more funding for a second cohort, and we hope to be able to train 12 to 14 new faculty if we can convince people to invest the time and effort. Yeah.
Thank you. Kamlin Masuda, who's from the pharmacy school faculty, says this is a great program. How do we sign up to get trained, or who do we contact to get trained? So if people want to become master trainers, how do we go about doing that?
I think you can reach out to Crystal. Crystal, you want to pop your email or something into the chat? Because Crystal is our project manager for this. And we, as soon as we get an idea of whether the funding is going to materialize, we are going to start looking at who we'll reach out to for to become trained. And pharmacy, that would be, wow, I would be totally jazzed if we could get pharmacy in that, because we need pharmacists. You guys already talk to patients and families. You already do. What's missing is bringing you more fully into the endeavor and the conversation, and bringing you on board as, fully a member of the team that takes care of people. So yes, please do reach out to Crystal. You can always reach out to me as well. Department of Geriatrics.
Oh, sorry, go ahead. I think
No, go ahead.
every physician deals with serious illness of some kind. Of course, geriatricians and palliative care physicians do that more than most, but because we deal with a lot of end of life issues. But honestly, every physician does. So I would think in an ideal world, all physicians would get this type of training, all medical students, all nursing students, all pharmacy students, all of the health professions, certainly social workers, all of them should get this type of training, I think.
Yeah. When this curriculum was first developed, it came out of palliative care work at University of Washington, their Department of Oncology. And it was aimed at a pretty high level. So physicians, nurse practitioners, residents, that's the level at which this training was targeted. I was involved in some additional training. And by the way, Kaiser it really is getting excited about this, and sent many of their staff to get Vital Talk training. But they're now opening it up to social workers. And this is at the Vital Talk faculty training level, okay? So it now includes physicians, nurse practitioners, nurses, I believe, and social workers. Anybody can take the Mastering Tough Conversations course, which in and of itself is highly valuable. But if you really want to get behind the curtain to really see what that pedagogy is all about, then it's the faculty training that you want to do.
Right.
There are also conversations on Vital Talk about chaplains and the chaplain role in serious conversations. And I think that would be really exciting to explore more in Hawaii also.
Yeah, I think what, Crystal talked about, where there are different disciplines coming to the table, there's a level at which how they interact among themselves on a team is so important, right? So when you have a team that really can knock it out, and work well together, that's just amazing. And then you layer on this high skill level of communication, and that team will be able to work wonders and provide much better care, I think, for our people.
Great, thank you. Our audience, do you have any questions? Please type them into the chat box. While we're waiting for questions, I just wanted to thank our team for coming on today to our grand rounds on this really important topic. It's so important that we communicate well with patients and their families. Michaela has put the evaluation link into the chat box. Please use those. If you want CME credits, you need to do the evaluation. And we're getting some comments about how people have really enjoyed your presentation. Any other questions? Give it one more minute.
Say,
yeah, please go ahead.
While people are, I do want to say that HPH has been really helpful in terms of CME for various disciplines. And so if anybody wants, a training set up, then Michelle and her team can help figure out the CME part of it, so you don't have to.
Yeah, and I wanted to emphasize for the training that we have for the 4 hours is 3.25 CEs, which includes social workers, obviously the providers, the nurses, and pharmacists, and psychologists. So yeah, we've got everybody covered.
That's
so awesome.
wonderful. I do know that some of the fellows are in the audience and you recently had this Vital Talk training. Would any of you be open to sharing your experiences? You can unmute and yourselves and show your faces and talk a little bit about how your training went. Any fellows?
I thought it was, hi, I'm Elaine Takane. I'm a Jerry Fellow. I think it was a great experience. I felt like I was in a safe learning environment working with my peers and then also in front of them. And the format was not what I was anticipating. I thought we would go on this and like do a full scenario, but there were these appropriate pauses where you could discuss with the trainers, get ideas from your peers, and then actually go back in and practice clinical skills. So I thought it was really invaluable and I'm glad we got to do it together.
Thanks.
Thank you, Elaine. Any other fellows have any input?
Yeah, I don't know if you can see me or not. My device is being a
Ashok, I
little-
can see you.
Okay, got
We
it.
can see.
But hey, my name is Ash. I'm one of the Jerry Fellows. So I thought in addition to the actors being amazing, I thought even the format of the lecture part, where you think sometimes that gets, you know, we've had those topics and those ideas before, but it was just displayed in I can't put a finger on it, just displayed and portrayed in a way that just made a lot of sense. I guess maybe interplayed along with the scenarios, and maybe it was that, or maybe it was something else, or maybe it was just the way that the trainers were taught. But it was really stuck with me more than some of the other times we get lectures about the same topic. So I think it was done really, really well.
Thank you, Ashok. Okay, well, I don't think we have any more questions and we're almost at 1:30. So I wanted to again thank our speakers, Ray, Rita-Bell, Beth, and Crystal. Thank you so much for your talk today and also for all you're doing for our community in this Vital Talk training, which is so critical for good care of our patients. Thank you, everyone. Don't forget
Our
your
pleasure.
evaluations.
Thank you.
Take care. Bye-bye.
Bye-bye.